Hello, everybody. Do you hear me on the back? Okay. Start? Okay. Good afternoon, everybody. Thank you very much for being here. I'm glad to moderate this session with Julio. My name is Saeed Idrisi from University of Brussels and University of Ghana. I'm glad to moderate this session together with Dr. Julio. Would you please introduce yourself?
Yes. Thank you, and thanks for the organizers for inviting us. And I'm Julio Mijangos from Mexico. I'm working at the Hospital Civil in Guadalajara, and it's a pleasure to be here with Dr. Said.
Okay, but anyway, we'll start without any ado with our first speaker. Thank you, Omar, for being here. Omar El-Madhoun, yeah? He's an anesthesiology critical care consultant at Mayo Clinic and assistant professor of anesthesiology, as well as a clinic of Alex School of Medicine. He will talk about innovation in pulmonary embolism management. Please go ahead.
Perfect. You can hear me okay? All right, perfect. Hello, everyone. Assalamu alaikum. And thank you so much for having me, and thanks for the kind introduction. Today, I was given the task to talk to you about everything PE, where we stand, what we're missing, and where we're going with innovations. So we'll go ahead and get started. So we'll talk a little bit about some outcomes related to the traditional approach with PE management, and then discuss very briefly some gaps and challenges in classification and risk stratification in PE, revisit an old therapy to see whether it deserves a second look, and then briefly talk about some innovation percutaneous procedures as well as ECMO for PE management. And then we'll bring it all together. So, you know, even though PE is an ancient diagnosis, we knew about it for over a century, our outcomes are still far from perfect. PE continues to be the third leading cause of death after CED and stroke. And mortality is still, again, not perfect. This paper looked at the mortality over a 20-year period. And what it showed that over the study period, the mortality is actually worsening. You would hope that the more you know about disease, the better the outcomes become. But unfortunately, that's not the case in PE. And you know, especially in the high-risk PE, there are some periods of stagnation, but the overall trend is that it's getting worse and worse. And not only when it comes to mortality, but also other outcomes as well. So this is a Dutch paper that was published 2 years at this point, looked at rehospitalization rates in PE patients after 1 year, and rehospitalizations were as high as 50% coming back with cardiopulmonary symptoms. And of course, this has its own financial implications on the healthcare system. So what we're showing here that we're losing when it comes to PE on multiple fronts. The question becomes, why is that the case? Why are we not doing well in PE management? One of the reasons is because we lacked progress for over half a century. Again, we knew about PE for 100 years. We talked about using anticoagulation for PE management back in the 1960s. We introduced the idea of having thrombolytics in the late 70s, early 80s, but that was basically it for 50 years. And of course, if we're not innovating, then we're not going to change the outcomes. Luckily, though, the pendulum has swung the other direction, and now there's a lot of renewed interest in studying PE, and there's a lot of investment in catheter-based therapies. So I do think PE will have better days in the future, but this is one of the reasons why we lacked progress for so long in PE management. In addition to lacking progress for 50 years, we still have a lot of challenges in classifying and risk stratifying PE patients. I'm pretty sure the audience can relate to a lot of PE cases when the patient looked okay, was only on 2-liter nasal cannula, ambulated to the bathroom coded, and a code blue was cold. So that is one of the issues that we rely so much on classification using the European Society of Cardiology and the American Heart Association, looking at PE in terms of intermediate and high risk versus submassive or massive PE, not realizing that patients do not follow boxes. PE is a very dynamic disease. Patients can progress over the spectrum and can worsen. And because we rely on these, we forget also that PE is an RV problem. So in order to get a systemic hypotension, at that point it might be already late in the game and we missed the window for intervening. So what's the solution for this? I like to think about PE in terms of a continuum, but not boxes. Similar to kind of the SKY classification when it comes to cardiogenic shock, patients go through stages before the arrest in PE. So I like to think about it as submassive to massive with multiple stages in between. So we have data to suggest that there are specific patient population, PE patient population, that tend to do worse. And those with saddle PE with proximal DVT, because they can have further embolization, going to a massive PE, those with clot in transit, and those with normotensive shock patients, meaning that they're able to compensate for their malperfusion, but you get a cardiac index, even though they're looking good. You get an echo, you see the cardiac index to be less than 0.1, 2.2 with elevated lactate. If we have these patients, if we know that they tend to do worse, then what we need to do is to intervene on them early on. Other innovation when it comes to scoring, we have tons of scores when it comes to PE. The problem is, again, they do not identify patients who are ready to fall off the cliff. What's the solution for this? This is a new study that showed that the composite shock score was published a year and a half ago that kind of combined all the high-risk factors for PE, including tachycardia, DVT, saddle PE, BMP, and troponins. And it's a 6 out of 6. If you have 6 out of 6 point, then the chances of being in a normotensive shock state is as high as 60%. So knowing that, that will help us kind of identify those patients early before they deteriorate. And of course, we need more data to suggest the validity of this score, but so far, it's very promising. So I'm not here just to state problems, we need to look at solutions as well. So let's revisit an old therapy, which is thrombolytics. So again, thrombolytics kind of started back in 1970s. There's a paper that showed improved outcomes, but at a very high risk of bleeding. So it made it kind of lose the favor for 20 years. Then another paper came in 1995 that showed significant improvement in mortality that became the foundation in PE management. The only problem with that paper that became the foundation in a very prevalent disease, that was an RCT that was based on 8 patients. Imagine you have an RCT guiding your therapy based on 8 patients. That said, so this paper showed improvement in hemodynamics and mortality with the use of thrombolytics. And this was consistent across all the studies. This is another meta-analysis that looked at all the PE patients in the United States that received thrombolytics. Was still consistent that there is improvement in mortality, but the problem with that is the number needed to treat was 59 and the number needed to harm was 18. So you improve mortality, but it comes at a very high risk, including major bleeding and intracerebral hemorrhage. So it's not a benign intervention. So what's the solution to this? We need to go back to pharmacology and understand that, as well as physiology as well, and realize that all the data that came from thrombolytics and PE came because of MI data and stroke data. But it's very different. Remember that pulmonary circulation receives 100% of the cardiac output, and we still give them 100 milligram of TPA. The coronaries receive 5% of the cardiac output, and we still give them 100 milligram. The stroke, the same thing as the same dose, which really doesn't make sense. So we know that the therapy works, but it causes complications. So maybe it's time to use lower doses of this therapy. So what do we do? There are a couple of studies that show promising effects. So this is a Turkish pilot study, looked at 37 patients who all were in massive PE, meaning they were on vasoactives, came in, they got 25 milligram over 6 hours, 36 out of 37 survived, left the hospital with 0 major bleeding. So it's not about the medication, it's about the dose that we use. And personally, this became my practice in PE management, because I can always give more, but I cannot give less. So if it doesn't work, we can give another 25, which actually happened in this paper. 2 patients required extra doses, so they got another 25, but that was more titrated with no complications. I come from Mayo Clinic, Rochester. Mayo Clinic, Florida has the practice of doing peripheral TPA over 24 hours. So they do not catheter-directed, but they do peripherally 1 milligram per hour for 24 hours, and they still showed improvement in outcomes with no major bleeding. So it works. We should still use it, but we should reconsider the way we use it and the dose we use it. Moving on. So other innovation in PE management becomes the percutaneous procedure and with rapid evolution. So catheter-directed interventions for PE management began in the 1990s, kind of exploring the idea of having mechanical fragmentation and local delivery of fluidics, with devices being developed and tested in the 2000s. Initially, these were used for only high-risk PE with contraindication through thrombolysis, but with more and more data that we're getting, we start to apply them more for the intermediate high-risk patients who are not responding to standard therapy. However, over the past decade, there was a lot of advancement, a lot of industry interest in these, of course, with capital investment that made those devices go to the recommendation, including the American Heart Association and the European Society of Cardiology. And the current evidence shows promising outcomes. However, the results still vary by study and patient population. But keep in mind, despite the capital investment and potential industry bias, this may impact the available data. However, given the improvement, and there is some improvement in the data, these made into the recommendations. So currently, the European Society of Cardiology recommendations suggest the use of percutaneous catheter-directed treatment for high-risk PE in which thrombolysis is contraindicated or has failed with Class 2A Level C evidence. These continue to progress. These continue to come into the market. I'm not going to give you all the details. To summarize them, the way I like to think about the PE percutaneous procedures, they're either depending on retrieval aspiration systems versus delivery of fluidics. And here I'm showing all the different sizes, all the RCTs that are available, and the RCTs that are ongoing. Keep in mind that some of the retrieval aspiration systems, they have huge catheters that we're introducing up to 24 French. So those are also not very benign. There's a lot of data, a lot of bias, a lot of industry influence, but what do we know about these procedures so far? This is a summary of all we know about these procedures. So when it comes to mechanical thrombectomy, we do know that they have specific benefits. We do know that they avoid pharmacological complications. They lead to rapid reduction in PA pressures and on-table improvement in right heart function. They do have, based on the data we have so far, low morbidity and mortality and shorter ICU length of stay. The complications include, they're still technically challenging. We looked at our own outcomes at Mayo. The first 3 years, we did not have the best outcomes, but the more we're doing them, we're learning them, and the complications are less and less. But what are the potential complications? These include aspiration-related blood loss, damage to the cardiac structures or pulmonary artery because of the catheter stiffness and size. What about catheter-directed thrombolysis? Well, the benefits we talked about earlier about thrombolysis in general, they work, but we need to give lower doses, and that's exactly what these devices do. The problem with them, they still have a very high ICU length of stay because you have to do it over 24 to 48 hours, and these patients need to continue to be in the ICU for monitoring. Their complications, they have better safety profiles compared to systemic thrombolysis, but this is not completely to zero. So if you look at systemic thrombolysis, they lead to major bleeding in up to 10%. In these cases, they're down to 6%. So they're better, but they're not zero. The same thing when it comes to intracranial bleeding. With systemic thrombolysis, they're up to 6%. With these devices, are 2%. So we're improving, but we still need even more better devices. This is what we do in the US. This is a paper that was published in 2024 looking at all the trend nationally in the US, looking at all the PE patients receiving other therapies other than anticoagulation. And you see the trend, that all the catheter-based interventions are on the rise significantly. All the mechanical thrombectomy cases are going up. Catheter-directed thrombolysis is going down, and systemic thrombolysis is going down. In fact, what this paper showed that 20% of those patients who are supposed to receive systemic thrombolysis actually receive them, which tells you there is poor buy-in from the providers. But you'll see more and more, and this is, I think, where the future is headed for these patients, more catheter-directed and more mechanical thrombectomy. Remember when I told you there was a lack of progress over 50 years? It kind of went the other extreme. And now we have over 14 studies currently looking at PE and the different interventions. So I think the field might look very different in the coming year or two, but we're still waiting the result for these RCTs to come. So we talked about some of the challenges. We talked about using lytics and percutaneous procedures. What about ECMO for PE? If you do know the pathophysiology of ECMO, of PE, then use ECMO makes perfect sense, right? So PE is all about the right ventricle, is all about the failing right ventricle. And if we know that pathophysiology, then it makes sense to use ECMO because ECMO is our fastest intervention to offload the RV, to restore hemodynamic stability, to have time for venous decongestion and restoring of end organ perfusion. In the CPR situation or the ECPR situation, it buys us time for both the PE response team to decide on further interventions for neurological outcome determination and for evaluation for chronic diseases. That said, even though it makes sense to use ECMO, it has not made it strong in the recommendation. This is the European Society of Cardiology recommendations, and if you look at it, ECMO may be considered in combination with surgical embolectomy or catheter-directed treatment in PE patients with collapse or cardiac arrest. So very late in the PE management with only class 2B level C evidence. Despite the lack of recommendation, we're seeing more and more, especially in my center, of PE patients being placed on ECMO. This is a German paper that looked at 1.1 million cases, PE in Germany, up to 2019, and ECMO was used in 0.2%, so a little more than 2,000 patients, and you see the trend that we have. It's in sharp increase in PE being treated on ECMO. So you'll see more of it in the future, and we need to familiarize ourselves with this modality. I think in my mind, the most important questions when it comes to ECMO for PE is when should we initiate it? Should we do it reactively versus proactively, early versus late? We were writing a paper on this. We spent hours to try to find the perfect time or literature guidance on when to start ECMO for PE. We could not find much. So we had to go back to the pathophysiology of PE. We do know that most PE patients do okay for the most part, but once we get into the shock phase, we know that 70% of patients who die from PE die because of a rapid cascade of events within hours of onset symptom. So if we know that patients, when they get into the shock phase, it's a sharp increase in mortality, this suggests that we should not wait for the CPR situation. We should not wait for the cardiac arrest situation, because once you get there, the mortality is 70% and higher. So PE management should not be reactive, it should be proactive. The next question, very important question when it comes for ECMO in PE, what are the different goals of ECMO? Should we use it? Some people think about it as a standalone therapy. Let's put the patient on ECMO, wait for the thrombolytic pathway to kick in, the intrinsic fibrinolytic pathway to kick in, or should we use it as a bridge to reperfusion therapy versus as a bridge to end organ recovery? There's a lot of conflicting data in the literature, but I'll tell you what we have so far. This is a meta-analysis that looked at over 6,000 PE patients on ECMO and compared the outcomes related to the different interventions and goals. This is what we know so far. We do know that if you use ECMO systemic thrombolysis, it was the highest rates of complications and mortality, up to 57%. We do know that ECMO with catheter-directed thrombectomy, there was the best outcomes with 28.6%, and as standalone, the outcomes was 45.8% mortality. So the conclusion of this, one of the best meta-analyses we have so far, over 6,000 patients, that ECMO has a role in PE, but it should not be used as a standalone therapy, and it should be combined with other reperfusion strategies. So how about we bring it all together now? So this is the summary. This is what we know based on the literature we have so far. We do know that thrombolytics work. They improve the hemodynamics. They can be rapid, but that's basically it. We do know that anticoagulation is safe, is cost-effective, is data-driven, but they don't help us in the ICU when we're coding our patients. We know that we're moving away from catheter-directed thrombolysis to avoid lytics, and we know that mechanical thrombectomy can improve the hemodynamics on the table and symptom relief, but we still don't know the long-term outcomes. Finally, for ECMO, it improves the hemodynamics and buys you time for other interventions to kick in. So what do we do at Mayo? This is basically our pathway, internal pathway. So we think that any patient with high-risk catastrophic PE needs an ECMO consultation. The moment they get on ECMO, we talked about look at the profile for these patients. If there's any contraindication for thrombolysis or a high bleeding risk, then we go to the mechanical thrombectomy in IR or cath lab ASAP. If there is no contraindication for thrombolysis, we can talk, we do more of a PE response team meeting, talk about mechanical thrombectomy versus systemic thrombolysis, and when we do it low dose. We don't just go straight to the 100 milligram. And if there's no improvement with these interventions, then we go to mechanical thrombectomy within 2 to 4 hours. In the intermediate high risk, as I mentioned at the beginning of my presentation, there are specific patient populations that we know they don't do well in the submassive. Those with elevated lactate, with low cardiac index, severe RV dysfunction, syncope, and central class with proximal DVT. If we have those patients, we take them to the cath lab within 24 hours. However, if they lack these features, we keep on anticoagulation, we monitor them, and send them to the floor. With that, I have less than a minute, so my take-home messages: PE is a dynamic disease that requires a nuanced approach. The good old anticoagulation might not always suffice. Less may be more when it comes to lytics, and PE intervention is rapidly developing, with the field maybe looking very different in the coming years. ECMO has a role in PE, can help cool things down, and works best when initiated early and combined with reperfusion strategies. And always prioritize what's best for the patient and don't rely on boxes. Thank you so much.
Practical reason, we make some change. I think that the next speaker will be Michael Pinsky,
Yes, it is.
which he will be talking about functional hemodynamic monitoring as a precision diagnostics tool for cardiorespiratory insufficiency. Please go ahead.
Okay, thank you. Is it ready? Okay. Is it working? Okay. This is my own clicker. Hello. We did a small change in the program. This is going to be something really that just happened and is cutting edge for the practical application of closed-loop resuscitation. My conflicts of interest haven't changed since yesterday, but the important one is that we have a system that defines cardiovascular insufficiency, which I'm using to run this algorithm. We are doing this on purpose because we did not want to have any company block other companies from using machine learning to diagnose and treat critical illness. So this is an open patent that we allow everyone else to use as well, so that no one can prevent others from doing it. Okay. I'm going to describe a closed-loop precision resuscitation system. We will identify the patient who has inadequate oxygen delivery, which we're going to call shock, to meet their metabolic demands. We're going to define if the cardiac output will increase if they give fluids, and if so, by how much. And the expression for being volume responsive is fluid responsiveness, preload responsiveness. We'll define vasomotor tone, and we'll define ventricular function. So as we've shown many years ago, the functional questions that you ask in a patient is my patient in compensated shock? Because if they're hypotensive and no urine output, et cetera, the mortality rate is very high. You want to get them early. Second question is, will their cardiac output increase if you give them fluids, and if so, by how much? The last speaker talked about pulmonary embolus. Give a person with massive pulmonary embolus a liter of saline and you will kill them. Okay? Really easy. It's a good way to kill somebody. Saline is dangerous. If you're not volume responsive, you shouldn't be giving the patient fluid. And also, you need to know if vasomotor tone is increased or decreased, because I can be hypotensive because I have no cardiac output, but with normal vasomotor tone. And finally, is the heart able to maintain flow under pressure without failing. I submit to you these are the only questions you ask in the acute resuscitation of a critically ill person. So compensated shock is basically a machine learning approach, which I'm not going to go into. We're going to assume the patient is in shock. Why do I care if they're volume responsive? Well, the reality is that in all the studies that have been done up until today, if you look at people who present to the emergency room or from the floor to the ICU or whatever in shock, and you look at the percentage of patients who are responders, meaning their cardiac output goes up when you give them 500 mLs of fluid, the answer is that it's only half. Now, if you play baseball, a batting average of 500 is pretty good. But if you're a doctor, that's terrible. What it means is that if you give fluids to every single patient in shock as the first thing you do, you'll be giving the wrong treatment to half of them. And furthermore, over-resuscitation increases mortality. As was shown by Bellamy, under-resuscitation of patients is not good and can cause shock in surgery, and over-resuscitation has the same thing with venous hypertension. Well, I'm not in the operating room, I'm in the ICU, and my patients come in with complications. So the threshold value of no fluids versus fluids is much, much tighter, so we have to be extremely precise when we give fluids. Saline is dangerous. The body has no defense mechanism for venous hypertension, and it causes organ failure and mortality higher than hypotension. We can use dynamic interactions of positive pressure breathing to look at volume responsiveness. Since the heart is in the chest, increases and decreases in intrathoracic pressure will affect the pressure gradient for venous return. And this created a concept known as dynamic parameters that we populated initially 25 years ago and have now been accepted by most of the societies of critical care medicine as the appropriate way of determining if a person is volume responsive. In this review article that Xavier Monet, Malu Melbrine, and I wrote a few years ago, you can see that the number of different tests that you can use to determine if a patient is volume responsive is really quite good. What we're going to use in this system is pulse pressure variation and stroke volume variation, the original ones that we described 25 years ago. The second question you want to ask is arterial tone increased, decreased, or normal? And I want to take a step back now and do just a little bit of physiology. Let us assume that you have an arterial pulse and the arterial pulse goes up because the stroke volume went up. The slope of this line is called arterial elastance. So watch, if I have a given pulse pressure and a stroke volume, and for the exact same stroke volume I have a lower pulse pressure, I must have a decreased arterial elastance. And for the same stroke volume, if I have a greater pulse pressure, I must have an increase in arterial elastance. And this is not physiology, this is physics. This is how we define things. So by looking at the ratio of pulse pressure variation to stroke volume variation, I know vasomotor tone. In you and in I, our pulse pressure variation to stroke volume variation right now, breathing spontaneously, is about 1.2 to 1. Pulse pressure is a little bit more than stroke volume because of the compliance of the vasculature. Okay, but if your pulse pressure variations to stroke volume variation is less than 1, you're vasoplegic. Gounod used that to assess whether he could wean patients off norepinephrine. In a study of cardiogenic shock patients, what he did was he looked at the level of their pulse pressure to stroke volume variation, which we term dynamic arterial elastance. And as you can see, in the patients who, when they decreased the norepinephrine, the blood pressure didn't fall, had a dynamic arterial elastance or a ratio greater than 1. But if they didn't, it went down. So they said, let's wean patients from norepinephrine with a normal blood pressure only if they have a dynamic elastance greater than 1. And they were able to get the patients off norepinephrine 5 hours earlier than the other group without any hypotension. So there's hope on the horizon, precise resuscitation. This is not new. This has been proposed and recommended by the American Thoracic Society, the European Society of Critical Care Medicine, and the Society of Critical Care Medicine in the United States for about 15 years. Let me show you what it is. This is the algorithm that we developed and I published in 2004, which is 21 years ago. This is not new. You ask the first question, is my patient stable? The answer is yes or no. If they're stable, have a nice day. But if they're not stable, you ask, they're in shock. Are they preload responsive? Remember, half the patients will not be preload responsive, half will. The answer is yes or no. But you don't stop there. You say, are they hypotensive? And to have decreased vasomotor tone. If they're volume responsive, it's yes or no. If they're hypotensive with decreased vasomotor tone and shock, then they need not only fluid, but vasopressor. But if they're hypotensive but have normal tone, that's like a hemorrhagic shock patient who's hypotensive. All they need is fluid because their blood pressure will go up. The other half the patients aren't volume responsive. Do they have hypotension with decreased vasomotor tone? If the answer is yes, who do you know is hypotensive with decreased vasomotor tone but not volume responsive? A septic shock patient. What do you treat them with? Norepinephrine. But if they are they're unstable, they're not volume responsive, they may be hypotensive, but they don't have a decreased vasomotor tone. The problem is between my two hands. I don't know what it is, but it's right here. Cardiac shock, tamponade, pulmonary embolus. Okay? And you can recycle this. And so what we were able to do is use input variables of mean arterial pressure, heart rate, and various machine learning things such as heart rate variability metrics and dynamic parameters of pulse pressure and stroke volume variation and pleth variability to determine cardiovascular function. So in support by the Department of Defense, we used an algorithm called resuscitation from shock using functional hemodynamic monitoring, or REFIT, which was originally proposed in 2010 as an open-loop resuscitation algorithm to treat patients in shock in a large multi-center trial in Europe that wasn't done because we didn't get the funding to do it. We did two different REFIT algorithms in our animal model of hemorrhagic shock. One was using mean arterial pressure and mixed venous oxygen saturation targets. The second was to be more realistic and say we're using non-invasive mean arterial pressure and a heart rate. If your heart rate is too high, then we'll say you're in shock. So this is the algorithm. Software closed-loop control decision support. Is my patient stable or not? If the answer is no, are they hypovolemic? Give them fluids. You target, in this case, the mean arterial pressure and the heart rate. And the algorithm for the subtask, do you give them fluids? Do you give them norepinephrine? Do you give them dobutamine? And I'm going to go through the subtasks in a second because that's unique. If your stroke volume pulse pressure variation is less than 10, you're not volume responsive, they don't get fluid. But if it's greater than 10 to 30, you give them 5 mLs per kilogram, 30 to 50, 8, and greater than 50% stroke volume variation, you give them 10 mLs per kilogram. And similarly, with norepinephrine, if they're hypotensive, after the first dose of fluid, you start norepinephrine, and then you would continue up on doses in the 0.02 microgram per kilogram per minute dose. And you only wean them if they've been stable for one cycle of 15 minutes and their dynamic arterial elastance is greater than 1. This is an example of our paper this last year of one of the animals who had hemorrhage shock, in which during the first bleed period we were withdrawing blood at 10 mLs per minute. It took about an hour and a half for them to get profoundly hypotensive. As you can see, the mean arterial pressure is quite low. We wait 30 minutes. They get a unit of blood, that's the red line, and then they get periodically fluid or blood as necessary to maintain a stable mean arterial pressure. And as you can see, a mixed venous oxygen saturation that's good, and the lactates go down. Did this work? Yes. When we compared both our invasive model, REFIT 1, and a totally non-invasive guided model, to the time of first stabilization, meaning that in the last 15-minute cycle we said, don't change a thing, they're stable. The time it took as compared to a critical care physician, a senior cardiothoracic ICU critical care physician, the time it took to get them was the same. So based on that, the military said to us, that's nice, but what we want is a non-compressible hemorrhage, as would happen if you were shot in the abdomen or had an explosion or severe trauma. So we want you to create a model of totally non-compressible hemorrhage, where no matter what, the animal continues to bleed because they've been shot. Well, we weren't going to take a gun and shoot them, so we said, what are the models out there? And they came up with a liver laceration model, which was developed by the Army about 10 years ago, and that's what we used. And so that model, if left alone, and it's a 4 centimeter by 4 centimeter cross life that goes through and through the liver twice. I personally cut the liver twice. You cut the hepatic arteries, portal veins, blood just squirts out. They become hypotensive really fast. We wait until the mean arterial pressure goes to 30, which doesn't take long, and then we close the abdomen so the blood doesn't get on the floor, but we don't stop the bleeding. The hole's still there. After 30 minutes, we do what they do in the field, and that is to give a unit of blood and calcium chloride, just like they do in the field right now in all trauma conditions. We wanted to match that. And after that unit of blood, we started our resuscitated algorithm. This is an example of me taking the device, I don't know if you can see it here, on the lobe of the liver. This is the device itself. It looks like something from the medieval time that you'd use in a torture dungeon. Yeah. This was after the deed, as you can see. This is a picture of me holding the liver open. You can see the through and through cut in the liver that's quite bleeding. We then put them closed. This is an example within the laboratory of us doing just that, in which we only used heart rate and blood pressure to resuscitate. As you can see, after the second laceration, the blood pressure falls really fast. We pack and close the belly. And with the resuscitation of the blood and the fluids and the norepinephrine, we can get the mean arterial pressure up and stable for 3 hours. And in fact, the ability to resuscitate using this system and this model was just as good as a critical care doctor at the bedside doing it as if they were there from the very beginning. So we decided, if that's good, let's take it on the road. We have a stat medevac helicopter evacuation system at the University of Pittsburgh, and with the approval of the U.S. Army and our Animal Care and Use Committee, we did a study in which we took 2 animals, put them on a helicopter, flew them around for a while and brought them back, and 2 other animals that we took and drove out to a remote airport in an ambulance, put them on a helicopter and brought them back to our hospital as if you were transporting a person from a scene to a place where a helicopter could bring them back. They said, it turns out that this has never before been done successfully. I want you to know that I did not know that that was the case when we did the studies. I thought this had already been done. It had never been done successfully, period. This is the first time that's ever happened, and that was actually a surprise to me because it seems so simple. This is the infusion pumps that give us total intravenous anesthesia, infused fluid, norepinephrine. We didn't use dobutamine because at no time in the studies did the animals ever have heart failure, so at least in this model, dobutamine was not necessary. This is the ruggedized computer. This is an example of me and the head of the stat medevac helicopter system taking the animal. You can't see it, it's behind there, and there's the helicopter pilot. The head of Stat Medevac, Frank Guyette, is right here. My glasses are photoreactive, so I look like I have sunglasses over here. Going into the ambulance, and there it is in the helicopter. We put the cover over it so you don't see the face of the animal. So essentially, it goes into the helicopter. And this is the first animal ever to be successfully resuscitated outside of an operating room or hospital environment in which nobody touched the animal whatsoever during the entire time from the start of the orange. As you can see, the resuscitation went down. The dotted lines are the time it took to transfer the animal to the gurney, up the elevators, through the hospital, to the helipad, and put them on the helicopter. The flight, and came back, and to the end. The lactate was 1.1 when he came back from the experiment. Now, the animal was anemic. It was still bleeding, but it was stable and could have, after 3 hours, gone into surgery safely. This is the second animal we did, and you can see the flight was much longer. So then we went into the truck and put them in an ambulance. And there's the ambulance. We had to go about 30 minutes away to get to the flight, which is a reasonable transport you would imagine from the mountains or something out to the area. This is the example of the animal that went on ground and then transferred to flight and went over. The lactate, as you can see, was 1.7 after back in the hospital. We didn't measure anything during transport. There was a little bit of a bump in the blood pressure, but it pretty much stayed the same. And this is the second animal. This is the flight plan of the 4 animals. The first one was 24 minutes. It's in red. The second one, we decided to take a nice tour. They went about 50 miles out and turned around. To be example, halfway across the state of Pennsylvania, equivalent transport. Then we had the first animal that was driven to an airfield and brought back in yellow. And then the third one, we decided to take it out a long way away. So what we've shown is that we can resuscitate in a closed-loop system without a single human being there, using non-invasive methods of a life-taking hemorrhagic shock for up to 3 hours. This allows us to take patients from a central aid station called a Role 1 or 2 into a more advanced care place of a Role 3 or a major hospital, Role 4. It maintains organ well-being. All the animals were peeing, and maintains organ function just by giving fluids and pressors to optimize organ perfusion to a mean arterial pressure of 65. And this is, of course, the refit trauma care in a rucksack tracer algorithm. The implications of this are that we can now provide anywhere in the world expert resuscitative care independent of location or need for transport. You can start appropriate resuscitation in the field, on the floor in a hospital bed, or anywhere you are with all you need is an IV, a pulse oximeter, and an ECG. That's all you need. It is clearly a force multiplier for peripheral hospitals, emergency conditions, and other areas like that the military happens to be involved with a lot of the time. It also allows for standardization of personalized care in that you only need a certain amount of fluids and stuff to do all the resuscitation. It expands the ICU so that essentially you have an ICU without wall. Well, where are we going in the future? Well, we're doing a closed-loop modular system for FDA approval. It's in clinical trial right now. We're going to use machine learning to identify the individual response so that we can do personalized, precise resuscitation that'll define the amount of volume that we need. The third thing we're going to do is determine volume responsiveness during spontaneous breathing. And we're going to apply this system in totally unmanned helicopters, so the only thing that'll be living in there is the animal or human that's being transported. So functional hemodynamic monitoring guided resuscitation allows for clear decision rules for closed loop control, and it standardizes resuscitation for remote, austere, and low transport areas. Thank you for your attention.
Thank you very much, Dr. Spinsky, for this exceptional presentation. Now it's my pleasure to present our next speaker, Dr. Ghislaine Dufay. She completed her anesthesia and critical care medicine residency in Paris. She is currently the education lead of a medical surgical intensive care unit at the Toronto General Hospital. Her main interest is in medical education and echocardiography with a special focus on extracorporeal life support. And the talk from today is the use of transesophageal echocardiography in critical care. And the next topic is when tamponade is not an echocardiography diagnosis. Thank you very much, Dr. Cecile.
Thank you very much for the kind introduction. Just before I start, can I get maybe a show of hands of who's performing their own transthoracic echo in the ICU? Okay. What about the transesophageal echoes? Okay. So we'll talk about transesophageal echo in the ICU. Depending on where you're practicing, you may heard it referred to as a TE or TOE. I will refer to it as TE because that's how we say it in Canada. Excuse me. I do not have any conflicts of interest, just disclosure or disclaimer. For those who have issues pronouncing my name, it's very easy. It's Dr. Dufay, as in soufflé, with a D and one F. And I'm sure you won't forget it. So I could summarize my talk in 2 slides. Number 1 slides, when to do a TE. Whenever you do a transthoracic echo, and this is what you see. And the only conclusion that you can draw from this is that there is a heart and it's moving. If that's the answer you get, you should do a TE. Second slide that could summarize my talk is what is the only real contraindication to do a TE? I had one of my mentors saying the only real contraindication to a TE is when you don't have an esophagus. That's not untrue, but since I was given 20 minutes, I will elaborate a little bit more. And I'll start with the contraindication. So besides the absence of an esophagus, which again is a true contraindication, the absolute contraindications to a TE are going to be when you have a perforated viscus, when you have a tumor or a stricture, or when you have an active GI bleed. All the other contraindications are a relative contraindication, and it will depend on whether you can get the information with another test or how much you actually need to get the answer to the question to optimize the care of your patient. The complications, this is a very busy graph, and there are many minor contraindications, but the 2 ones that you really want to be aware of are the major bleeding and esophageal perforation. But as you can see, those are actually very rare. It's 1 out of 10,000. And in the setting of ICU, the most common complications were mainly dysrhythmias, atrial fibrillation. There's no reported mortality, although that can be biased because obviously if you have mortality, you may not be willing to report it. But in this study where they reported morbidity and mortality, it was again a complete heart block that necessitated cardiopulmonary resuscitation and other types of dysrhythmias and hypotension, but no esophageal perforation. That being said, the risk factors for esophageal perforation are mainly the age, female more than male, and if you have an intra-op TE, and that's probably because you're leaving the probe for a longer period of time when you're in the operating room. You also need to be aware that when the insertion of the probe is more difficult, when you have more than one attempt, that is also a risk factor for perforation. So if you have any resistance, the first thing to do is ensure that your patient is sedated and paralyzed. Some physicians will electively use a laryngoscope for introduction, and others will elect to use it only if you have resistance, but bear that in mind if you have difficulty introducing the probe. So for the indications, beyond there is a heart and it's moving, there are many situations in the ICU where you will require a transesophageal echo. I will not go through all of them, but I think there are a few where it's worth mentioning it. So the first one will be lack of echogenicity and inadequate transthoracic views, especially for patients who are post-cardiac or thoracic surgery. This was the case of a patient who was admitted to our ICU, had been placed on veno-venous ECMO blind, meaning they didn't use echo guidance. I'm not going to comment on this. This was complicated by pericardial tamponade. Patient was drained. They removed the pericardial drain, and after a couple of weeks, you can see that the patient is unstable again. I think you can start seeing here that you have something suspicious, but the quality of the views is nowhere compared to what you can see on a transthoracic echo, on transesophageal echo, sorry. And you can see here that hematoma compressing both the right atrium and the right ventricle. Another potential indication of a TE in the ICU is for fluid responsiveness. Some of you may be keen to use the inferior vena cava and the respiratory variation. Unfortunately, it's really not sensitive, nor specific in the setting of patients who are mechanically ventilated, and the superior vena cava is much more sensitive and specific for that matter. And for this, you will need a mid-esophageal view, and you'll place your M mode at the level of the SVC here to look at the respiratory variations. Next potential indication, patients who are in hypoxemic respiratory failure. Sensitivity for detection of intracardiac shunt is much better with a transesophageal echo compared to transthoracic echo. You also want to be able to exclude left-sided valvular disease. This was the example of a patient that was transferred to us for potential veno-venous ECMO cannulation. They told us the patient has a known bicuspid aortic valve and an endocarditis, but they have mild aortic insufficiency, so we don't think that the aortic regurgitation is a reason for the respiratory failure. So you can already see on the transthoracic view that the aortic valve is highly abnormal, but again, the definition that you will see on a transesophageal echo is much better, and you can also assess that this patient has severe aortic regurgitation. Needless to say that this patient did not need veno-venous ECMO. They needed a good dose of furosemide and a consultation with a cardiac surgeon, which they got, and things got better. When your patient is in respiratory failure with severe RDS, they may also be in the prone position. Obviously, you can get an apical four-chamber in the prone position, and you can assess at least your right ventricular size function as well as the left ventricular size and function, but you may not be able to get much more information. And in those cases, you may not want to put your patient in the supine position to get the information, and it's been proven that performing a transesophageal echo in the prone position is actually safe, it's not actually more complicated, and it would allow you to maintain your patient in the prone position. That's the example of a patient that was referred to us for COVID ARDS. Patient was transferred in the prone position. This is the only view that I could get, an apical four-chamber. You can already tell that the right ventricle is severely dilated and the left ventricle is being collapsed and compressed here. We proceeded to do a transesophageal echo in the prone position, and you can see here that you have a mass in the right ventricle, which was most likely a thrombus in that context, which allowed us to adapt our treatment and to anticoagulate the patient. Next potential indication, is guidance for ECMO cannulation. You can obviously use a transthoracic echo, but again, the visibility that you will get with a transesophageal echo is unparalleled. You can see the wire coming from the IVC here and the two wires in both vena cava, which again allows you to follow and monitor your procedure at any given time. So the situation of cardiac arrest, more and more physicians are including transthoracic echo in the setting of a cardiac arrest, but unfortunately it's been shown that when you use point-of-care ultrasound in that setting, especially when you're not trained, you have actually an increase in the duration of the CPR pauses. This was in reference to physician assistant, and you can see that consistently when you're using point-of-care ultrasound, the duration of the pauses are higher, except if you have an attendant who's formally trained for ultrasound. In comparison to that, you can see that when you're using the TE, you don't actually interrupt the CPR just to look at the heart. You can continuously monitor the heart, and the duration of the pauses are much shorter, even compared to manual palpation. So that allows you to do a continuous monitoring of your resuscitation. It doesn't interfere with the pauses, and it also allows you to look at the area of maximal compression during the resuscitation. So on the left, you can see here that the aortic valve is actually not opening when they're doing the compressions, compared to that side here where they adjusted the position of the CPR to allow the aortic valve to open. Some physicians have raised concerns about the fact that you're performing CPR while you have a rather rigid object in the esophagus. I would say the ones who are advocating for the use of TE in that context will say the benefits of and the risks in that context are not quite debatable, because your patient is already dead, so they cannot really be deader. I'm going to leave it out there. Last indication, aortic dissection. CTA is the imaging modality of choice when you have someone who has a suspected aortic dissection, very sensitive and specific, and allows you to identify the site of the intimal tear and the extension of the dissection. The advantage of echocardiography in this case is that you can assess the presence of aortic regurgitation and the impact of a potential pericardial effusion. So it's mainly for the patients who are unstable, where you will perform an echocardiography rather than CTA. But I would be very careful to rely on a transthoracic echo only. This is a patient who had a known type A dissection, but if you're only looking at a transthoracic echo, you may miss the fact that this was the flap, but again, you see it much better on a transesophageal echo. So if your patient's too unstable to go for a CTA and you want to potentially assess for a dissection, TE is the way to go compared to transthoracic echo. And finally, for the indications, and I would not advocate to do a TE just to look at the lungs, because they are already quite easily to image on a transthoracic echo, but if you're already doing a TE, you might as well look at other organs, such as the lungs and the pleural space, to help you guide your management. So the next question is, how do you train for a TE? How long does it take? I would say it really depends on what kind of examination you're doing. So if you're doing a comprehensive transesophageal echo, it's actually 28 views. That's what's recommended. But for a critical care TE, it really depends on your question. As I mentioned before, if you're doing a TE in the context of a cardiac arrest, you will have a very limited protocol, such as this one that has been described, with only 5 views. But for other indications in the ICU, you may need a more extensive protocol. This is a basic protocol that's been described more in the perioperative setting, but that can also be used in an ICU setting. But depending also on the population that you may have, you may need to be able to perform a comprehensive study. For example, in the center where I practice, we have a lot of patients who have just had a lung transplantation, and in those cases, you will need to be able to look at your pulmonary veins, and so you may need to be able to do a comprehensive study. When it comes to the basic perioperative or advanced critical care protocols, what's been shown is to reach proficiency, you will need at least 35 TEEs that have been supervised. That being said, if you have access to a simulator, that learning curve can be accelerated. As you can see in the intervention, they reached the level of the experts much faster when they were using a simulator, and that's the same for that study here. So I will summarize by saying when to do a TE, whenever the question cannot be answered with a transthoracic echo and you really need to get the answer and you don't have any other test to help you answer your question, when not to perform a TE anytime you have already an esophageal perforation, a stricture or a tumor, or you have active GI bleed, and it's most of the time safe. Remember that if you have any resistance, you want to make sure that you optimize your setting, and the protocol that you will be using will depend on the clinical question. And on this, I thank you for your attention.
Thank you very much, Dr. Duflo. And we will continue with the next presentation about the transesophageal echocardiography in pulmonary embolism. Thank you very much.
So, it's me again. I hope you remember my name now. So now I've chosen a bit of a controversial title. When is tamponade not an echocardiographic diagnosis? I still do not have any conflicts of interest. And I see some of you may be frowning, saying, well, tamponade is a clinical diagnosis anyway, so what is she going on about? I have 20 minutes to raise my case. So, and I'm going to start with the case. It's based on a true event, only the names have been changed. So we have a 34-year-old gentleman who had sickle cell disease and also pulmonary embolism and was left with severe pulmonary hypertension and was supposed to undergo a pulmonary endarterectomy. As you can see, he has quite a dilated right ventricle here, very hypertrophic, and some paradoxical septal motion all throughout the cardiac cycle, and you can see that his mean PA pressure was quite elevated before the surgery. Went on to have the pulmonary endarterectomy. This was uneventful, was started on therapeutic anticoagulation and diuresis, left the ICU after 10 days, and after 2 weeks, patients started having hyperleukocytosis, so the thoracic surgical team was wondering whether the patient was in tamponade. They performed an echo that showed that he had some pericardial effusion here, as you can see, and the conclusion from that echo is that he has a moderate pericardial effusion, no echocardiographic signs of tamponade. So the team thought, okay, probably he's septic, started him on antibiotics. 5 days after that, he's still not improving. The hyperleukocytosis is actually getting worse, and now he's also developed acute kidney injury. So the team consults the CCU team again with the same question, is this patient in tamponade? The cardiology team, who were residents, it was a Sunday evening, came to perform a TTE at the bedside at 1 in the morning. They said that there was no parasternal views, which is a bit strange because 5 days prior, he had good transthoracic views and that was closer to the surgery, but anyway, I wasn't there, so. Then they said the patient had grossly normal left ventricular function, a dilated right ventricle. They did fancy measurements on the IVC and said he was 2 centimeters with more than 50% collapse. Also did the trans-tricuspid and trans-mitral variation. Said there was no pericardial effusion, also strange given the fact that 5 days prior to that he had a pericardial effusion, and concluded that all of this was due to right ventricular failure. Didn't save the images, as frequently done. They did ask for a chest X-ray, which I don't think they saw, because this was the X-ray just immediately post-operative. I'm sure you see what the problem is already, but I'm going to leave it there. And at 5 p.m. the same day, now the ICU team, the rapid response team, is involved because the patient is in AKI. And they told us that they wanted the patient to be admitted to the ICU. I was on call, and they came to me and they said, the staff surgeon wants the patient to be admitted in the ICU. And I said, why? They said, well, the surgeon wants it. And I said, well, that is not my problem. And then they said the words. They said, we did an echo, there is no tamponade. So usually when someone says that, I start having coronary spasm and tachycardia. Looked at the images, couldn't find the images, so we went to repeat this echo. On top, you have the images that were done on post-op day 14, and at the bottom, the images on post-op day 19. What you can see is that the effusion has significantly increased in size. It's circumferential. You can see it along the left ventricle here and on the subcostal view. Also, very nice tracing on his ECG. And blood pressure, very nice electrical alternance and paradoxical septal motion, pulsus paradoxus, sorry. So obviously, this patient was in tamponade. Luckily, because I didn't trust what they were saying, we sent the patient for pericardiocentesis. They drained 700 cc's of sanguineous fluid, and everything improved. So the question now is, what echocardiographic signs were they expecting to see on this patient? And first things first, yes, tamponade is a clinical diagnosis informed by echocardiographic data. Briefly on the physiopathology, we all know that tamponade is the fact that you have an impairment of your diastolic filling here with equalization of the pressure and loss of your Y descent. And what happens is that you have accumulation of pericardial fluid, increased venous pressure to compensate for the increase in pericardial fluid, pericardial pressure. Then you have equalization between the right ventricle and the left ventricle, then equalization between the intracardiac and pericardial pressure. And eventually, when your intrapericardial pressure is higher than the intracardiac pressure, that's when you have a decrease in stroke volume. But obviously, this is a spectrum, and you may have different signs, depending on where you are on that spectrum. So, yes, it's a clinical diagnosis. What you will look for on an echocardiography is first the presence of a pericardial effusion, and then you will also look at the size, but it's very important to remember that the size does not always correlate with the hemodynamic compromise, because if you have a very rapid accumulation of fluid, the pericardial pressure will rise very quickly, while when you have a slow accumulation of fluid, the pericardium will have the time to stretch and to accommodate for that increased fluid. The next signs that you can see are the swinging heart, which is what you see here. Basically, the heart is dancing in the chest, and that is due to the fact that the two layers of the pericardium are no longer attached and fused with each other, so the heart is only anchored by the great vessels. You can also have a paradoxical motion of the interventricular septum, and you can also have the appearance of left ventricular hypertrophy. The next sign that you will see is the IVC plethora, which is a consequence of the increased intrapericardial and intracardiac pressure. It's a very sensitive sign, but it's actually not specific. It can be present in many other situations. You can also have dilation of your suprahepatic vein. Next echocardiographic sign is a chamber collapse, and you will expect first to see the collapse of the right atrium, which is also a sensitive sign, but not specific. It's only specific when it's more than a third of a cardiac cycle. And then you will have the right ventricular collapse. And it's really important to look at this in more than one incidence to make sure that you're not missing that collapse. And lastly, you have the respiratory variations through the transtricuspid and transmitral valves, which Again, it's just an exaggeration of the normal physiology. Normally in inspiration, you have an increase in the trans-tricuspid velocity up to 15%. That can be up to 80% in tamponade. And on the left side, you will have up to 5%, and in tamponade up to 40%, and that's if your patient is spontaneously ventilated. And if the patient is on mechanical ventilation and positive pressure, then it will be the reverse. So when you calculate your velocity, you would expect index of collapsibility that will be more negative than minus 60% on the right side if the patient is spontaneously breathing, and more than 30% on the left side. It's important to know that when your patient is on positive pressure ventilation, it may not reach those levels. The problem with those signs is that there are a lot of false negatives. The first one is you may not have a pericardial effusion that is circumferential, and it could be loculated. And in those cases, you may need a transesophageal echo. This was the case of a patient who was immediately post-lung transplantation, post-op day 1. This is a very lousy parasternal lung axis view. That's all I could get. But I would say the first thing that you can see, it's very difficult to see the left atrium. This is a descending aorta, and you may suspect that there is something abnormal here. I could have engaged in a very long discussion with the surgeon as to whether this patient needed to go back to the OR, but when we did a TE, you can see that clearly there's a hematoma compressing the left atrium here and on this side too. So this patient ended up having a re-intervention. And this case illustrates the fact that the transthoracic echo is really not sensitive, especially in patients who are post-operative of cardiac or thoracic surgery, that the size of the effusion, again, does not correlate with the hemodynamic compromise, and that one should not expect to have a swinging heart if your patient has a hematoma or if you have adhesions. And lastly, the expected sequence of chamber collapse is not applicable if your patient is post-thoracic or post-cardiac surgery, because you can see that the effusion could be anywhere where there's proline deficiency, as I call it, because it won't manifest the same way as someone with a fluid effusion. The second false negative is the patients who have RV hypertrophy or pulmonary hypertension. This is an example of another patient with a pulmonary endarterectomy, and you can see that the right ventricle is still quite dilated, so is the right atrium. A very thick right ventricle here. You can see there's a moderate-sized pericardial effusion, but there's no collapse of the right ventricle, but on the other hand, there's a collapse here of the left ventricle. And this has been shown that the sensitivity of an echocardiography in patients with right ventricular hypertrophy or pulmonary hypertension is reduced, and it's almost like the pulmonary hypertension is a protective mechanism for those patients. Next false negative, patients who are on ECMO. Because when you have someone on ECMO, irrespective of the type of ECMO that you're looking into, if you have a patient who is on venous ECMO with very poor lung compliance and very low tidal volume, you will not have the pulsus paradoxus, and you will not have the transmitral nor tricuspid respiratory variation if you have tidal volumes of 50 cc or 100 cc's. Very difficult to assess the CVP in those cases, and the compression of the chamber is variable. And that's also the case for someone who's on VA ECMO. You have also other false negative. I mentioned the fact that when you're on mechanical ventilation, the respiratory variations may be blunted. When you have severe LV dysfunction and very high filling pressures, you may not see the collapse of the chambers. And if your patient is severely hypovolemic or has intra-abdominal compartment syndrome, the IVC will not be plethoric. So even if your patient is actually in tamponade, you may not have a dilated IVC. You also have patients who may have false positive signs. This was a patient who was on VA ECMO, and you can see that at flow of 2.5 liters, you barely see the right atrium here. It's also very difficult to see it there. And we decrease transiently the flows of the ECMO, and you can see that the right atrium is fully open here, and same thing here, and there was not even a pericardial effusion. So in those cases, it may be that the negative pressure on VA ECMO is too high, and that's what's causing the collapse of the right-sided chambers. But if you also have a patient with a pericardial effusion and profound hypovolemia, you may have the impression that you have a collapse of the right atrium of the right ventricle, which will subside as soon as you give fluid. So the fact that the patient has a pericardial effusion doesn't always mean that they are in tamponade. So closing the loop on the first patient I showed you, is it that they didn't see that there was tamponade, or was there other signs to confound the diagnosis? So two things. Number one, as you can see here, there are some adhesions in the pericardium of this patient, which is probably what prevented the ventricles to completely collapse, because this patient was postoperative of a thoracic surgery, and you can see the fibrin strands here. But also, you still can see that the right ventricle is still quite hypertrophic. So yes, the pulmonary pressures are decreased immediately postoperatively, but the right ventricular hypertrophy would have taken more time to subside. And in those cases, you may still not have all the echocardiographic signs of tamponade. So I mentioned that before. Tamponade is a clinical diagnosis. Yes. It's true. I'm sure you all heard about the Beck's triad, where it says that one of the hallmarks of tamponade is that you have muffled heart sound, you have high venous pressure, and hypotension. So number one, I would say, all the patients who are in the ICU, to me, they have a muffled heart sound. It's very difficult to actually hear a lot on those patients. But what's also important to know is that the sensitivity of that Beck's triad is actually very poor. This was a case series of about 150 patients who were presenting to emergency department with pericardial effusion or tamponade, and the sensitivity of the Beck's triad was from 0% to 20%. The sensitivity of one finding was also 50%, and 37.5% of the patients were actually not, were only presenting with hypotension, a little bit more sensitive for tachycardia. What's even more interesting is that the Beck's triad, the first presentation of this triad was based on those 9 cases. And if you look at the blood pressure of those patients, I would say except for case number 4, they all have an narrow pulse pressure, but I would submit to you that those patients were not hypotensive. But that's what we're basing our Beck's triad on. And this is another series where they looked at patients who presented with tamponade. There's actually a subset of those patients that were actually hypertensive. And even the ones that were not hypertensive, except maybe for this one, were not actually hypertensive. And so the hypotension in pericardial tamponade, it's true if it's a very acute accumulation of fluid, for example, trauma patients or patients who are post-operative of a procedure, but it's actually very uncommon when it took a few days or a few weeks to accumulate. A few of those patients present with hypertension, and the reason for it is that you have a compensatory mechanism with your sympathetic nervous system that will keep your blood pressure as long as possible. And that's one of the reasons that if you're giving sedation to those patients, when you remove that sympathetic tone, that's when you unmask the fact that this patient was actually in shock. And this is a series of post-cardiac patients, post-cardiac surgery patients, where you see that when it's early tamponade, they were hypotensive, but all the patients that presented with late tamponade were not hypotensive. And in my experience, one of the most common sign is the fact that those patients are oliguric. Unfortunately, that is not a very specific sign, but I'm yet to see a patient who's in tamponade and who's still making urine, except for the patients who are on VA ECMO. This was the case of a patient who was on central VA ECMO. you can see there's a large effusion that had been increasing in size for a few days. And the only sign that this patient was showing at the time we did that echo was the fact that they lost their pulsatility. But other than that, blood pressure was otherwise stable, patient was still making urine, liver function tests were normal, and lactate was normal. Had a bit of a hard time convincing the surgeon that something needed to be done. And this is the echo after they drained the effusion, and you can see that the contractility has significantly improved. And most likely that was due to the fact that the intrapericardial pressure was so high that it was compressing the coronary arteries and causing some degree of myocardial ischemia. So in summary, I would really emphasize that the absence of classical signs of tamponade on echocardiography doesn't mean that the patient is not in tamponade. It's a clinical diagnosis informed by echocardiography, but please remember that hypotension is not a sensitive sign of tamponade, and most of the signs of tamponade are going to be nonspecific, and maybe it's time to find another triad. And so please remember that your echo machine still doesn't have a brain, especially if you suspect tamponade. And remember that the patients do not read the books. Thank you.
Thank you so much. Wonderful. Thank you so much to our three speakers for this illustrative and indicative approach. May I ask you please to come to the front, and the three talks will be open for discussion. Is there some, yeah, please go ahead.
Hello, my question is for Dr. Michael. Actually, you have talked about the fluid resuscitation, but there are certain challenging situations, like especially cardiac surgery patients. After having cardiac surgery, the fluid resuscitation become difficult because the assessment is difficult, like patient is having circulatory support like intra-aortic balloon support. We cannot measure the pulse pressure variation or stroke volume variation. Even sometimes collapsibility of the IVC cannot be seen because of the drains are there. The echocard means window is not very clear. And particularly patients are having hypertrophied LV, very sensitive to volume. They are feeling at the higher volume. So in that situation, maintaining cardiac output becomes really challenging. And we have the chest drain, and we can measure the volume, how much the patient is bleeding. In that case, would you like to suggest that we can give the maintenance fluid per hour, or still you will be stick to the like 10 ml or 8 ml volume boluses?
What did you say at the end about the maintenance fluid? The last sentence you said. Repeat the last sentence you just said. I didn't understand it. The question.
Like, would you suggest to give as a maintenance fluid, because patient will have bleeding for 6 to 8 hours post cardiac surgery, and we can measure the volume, how much patient is bleeding, because we have the chest drain. It is a visible bleeding. So okay. In that case, like crystalloid-colloid ratio or colloid-colloid ratio, in that way we can give hourly maintenance, or still we have to stick to the
Gotcha.
boluses?
I understand the question now. Thank you. Okay. If you have active bleeding chest, the classic cardiac surgery where there's a chest tube and there's draining at a fixed amount, you don't need to monitor that and manage it the same way, because there will be redistribution. And most of the time when a patient comes off pump, they give a lot of fluid from the reservoir, okay? So you tend to be relatively hypervolemic coming off cardiopulmonary bypass. So in general, we tend to wait for other measures of hypovolemia, such as decreasing urine output, before we give fluids, because the one thing we don't want to do is dilute the coagulation factors that are present in the patient. But if a patient is obviously tachycardic and they are needing pressors and their pulse pressure is very low, that means their stroke volume is very low. If they're on a balloon pump, of course, you can't tell that. Then you might want to give them fluids, but it's very difficult to match the chest tube drainage with IV fluids unless it's very large chest tube drainage, more than 50 mLs in a 5-minute or 10-minute period, because that represents active bleeding. And if that continues for an hour, then you suggest to the surgeon maybe you should go back to the operating room. So in general, you don't have to match the input to the output for the first several hours because of the plethoric condition that they get coming off the pump. They get all the fluid back. So they're actually volume overloaded, which is not a bad thing because they're going to third space it anyway. So we don't tend to be aggressive at giving fluids early on in the post-cardiac surgery patients because we expect there to be equilibrium of it. But if they start having a decrease in urine output, then yes. Okay? Other people's opinion?
One silly question, Mike, about that. What was the body temperature of the animals when?
Say again, please. Repeat again.
What was the body temperature of the animals after Rule 1 and Rule 2 when it came into the operating
We kept them in blankets so that their temperature,
The temperature was kept
38
low.
degrees at all
Okay,
times.
okay.
Yeah.
Okay. Other question from, yes, please go ahead. Okay, please go ahead, sorry. Yeah.
Thanks. I have a question for Dr. Doon about the pulmonary embolism. So the first question is that in patients that are going for thrombolysis, do you still give ASAP anticoagulation, and do you have what do? You use a low molecular heparin and then you give thrombolysis right away? There's a timing in this patient because we had that discussion. He got heparin and we are transitioning low molecular heparin now, even in unstable patient, and then when can we give the thrombolysis? The second question in this unstable patient is that thrombolysis and thrombectomy or thrombectomy alone. It wasn't clear from your slide, you're covered by you. And so in that specific population is that what do you do? Is that you combine, and when you choose to go for thrombectomy, even if the patient doesn't have really contraindication to thrombolysis. And the final part, and I'm sorry if I am asking a lot of things regarding this, is in the PETO trial, there was, of course, the PETO trial in New England, I think it was 2012, but there was no benefit in the intermediate risk PE for thrombolysis. But what about the high intermediate risk? Is that, do you ever consider low dose thrombolytic in this patient, or you just now go straight to mechanical thrombectomy?
So you'll have to remind me of some of the questions you asked, but I'll start with the third one. So in terms of submassive patients or the intermediate high risk, we're not suggesting that we should be giving those patients thrombolytics. Again, if you see the trend in the slide that I showed, we're giving lytic less and less. As I mentioned, 20% of patients who are supposed to receive lytics receive it nowadays because of the fear complications. That said, you also need to have the expertise and the number in your hospital to be able to do these procedures. So it depends on your practice. I'm fortunate enough to be working in a place where we have the expertise, so that kind of pushed us away from using thrombolytics and have very low threshold to go to the cath lab for a procedure. Now, did I have to push thrombolytics in submassive patients? I did, and as I mentioned, it's all about the patient that you have in front of you. I remember a patient that we just had maybe a couple of months ago. I did push thrombolytics in someone submassive, completely hemodynamically stable. But you look at the history, the patient had a syncopal episode the day before, which told me at that point it was severe enough that I dropped the cardiac output completely and had a syncopal episode. With someone who is normotensive, but you look at the chart, they're already hypertensive at baseline. So the trend was not going the right direction, and I did not want to code them 2 in the morning. So I did give it. And as I mentioned, I did give a very low dose, 25 over 6 hours. And by the morning, the tachycardia went away, the RV improved right away. So that's the first thing. In terms of the question about combining mechanical thrombectomy and
Thrombolysis.
Thrombolysis. I mean, you don't really need to combine them unless one of them fails, right? So again, it depends on what expertise you have. You know, the recommendation in the European Society of Cardiology, the latest recommendation says that you should start with the standard of care, which is thrombolytics, and if that fails, you go to mechanical thrombectomy. But if you do have the expertise and you were very comfortable and we showed our data that we're doing very well in the complication rates, then I would have the low threshold to go to the cath lab.
So you are at your center, you are going to mechanical thrombectomy in a high-risk hemodynamically unstable patient without thrombolysis then? So you're going against the
So how fast do I go to the thrombolytics? Or yeah, so if a massive patient on inotrope, I go ASAP. So we get that, we talk to the cath lab or the IR, we send them ASAP. If we have submassive and we have the pleasure of time, we do it within 24 hours. However, if the patient is becoming more and more hypotensive, requiring more inotropic support, and you don't have the team in front of you, then I need to save the patient, so I give thrombolytics. And then the last question, if you do have a patient who's decompensating, I would not worry about anticoagulation versus thrombolytics. I would just push it because I don't want to code them.
Okay, we still have one question from the gentleman here in the front.
Thank you, guys. Thank you for enlightening talks. I'm an interventional cardiologist, a structural specialist, and I do pulmonary embolectomies, and based on my training in the States, basically. So, look, as an area, I would say it's a very immature area of studies. There's so much variability. There's so much unknown. And I would take an example as MIs, for example. MIs, initially the outcomes was measured mainly based on mortality, but later on we look at LV dysfunction, heart failure, readmissions, and similarly with PEs. I mean, PEs, all the data is about mortality or length of stay in ICU. What about 6-minute walk tests at baseline? What about them developing post-PE syndromes and all the rest? So the point my colleague mentioned earlier about combining thrombectomy and thrombolysis is something actually I kind of from experience, not from any standard studies, go by the success measure to say that the procedure is successful is also, we don't have a measure. Like in coronary, we have a TIMI-3 flow. We know that's ECG changes. But with PE, what is a measure of success? Secondly, similarly, the chronicity of the clot that you retrieve. If a lot of time we retrieve clots in small fragments because they are quite fibrotic and they are chronic and they have a lot of fibrin deposits, which makes you wonder, maybe if we combine a thrombectomy with a catheter-directed lytics, or as you mentioned, actually, it was a very smart thing about that the pulmonary circulation gets 100% of the cardiac output. Maybe it's a low dose might have a better impact in if you have a chronic clot that you retrieve. So my point is a lot of the outcomes being studied are just rudimentary. Mortality, length of stay, but doesn't look at what's beyond that, and I'm one of the interventionists who follow these patients. I follow them chronically after a year, see how many of them actually have pulmonary hypertension, how many of them develop impaired, 6-minute walk test and all those sort of things. So that's my first point about this.
Very, very well taken, very good points. Again, I don't think that's specific to the PE population. Talking about mortality in all the patient population in the ICU, I do think that's not the end outcome we should be looking at. I did not mention surgical embolectomy. I did not mention the chronic clot. This was more of the acute PE. For us, if there's any concern for a chronic clot, we do not go to the cath lab. We do not.
No, but even with the acute PE, sometimes they are organized somewhere in the IVC and they embolize. Yeah. And then when you try to actually do mechanical thrombectomy, it's extremely difficult. Other pulmonary thrombus, they come like easy, like they come really fresh and easy. And even if we squeeze them on the table, you'll see them mushy. Unlike the chronically organized ones, you'll find them really hard. It's not like they are all acute. Some of them, they have been formed in the abdomen, in the IVC, and they just shower.
For sure. And if you remember my slide also, we talked about a lot of the data we have so far, but I had at the bottom of the slide a big question mark on long-term outcomes. and long-term functional status of the patient. We don't know these things, and that's, again, the summary of my slide. What we know that it improves the hemodynamics. We know that these procedures improve the PE pressure right away. Now, whether that's in terms of relevant long-term, we don't know. We know that data from after 6 months, after all the procedures kind of all come together. So these are, we know them based on the data we have so far, but based on what we have, I would go for something a little more benign than I would cause intracranial bleed.
And just one last thing, because of the pulmonary cardiac tamponade, actually. So we always have this notion about shock being low pressure. Shock is a state of low flow. You can have pressure even with low flow. And funny enough, last Wednesday actually, I had a similar case, heart failure, just discharged from another hospital, walked into my clinic, blood pressure of 70. And despite giving him fluid, actually fluid made him worse initially, which we used as initial measure to just temporize things until I get the setup ready and stuff like this, but actually made it worse because he actually had an elevated filling pressure because he's a patient of heart failure. And the minute you gave him the fluid, you raised the RV pressure, which shifted the LV pressure lower, made it more compressible, and then worse shock. So exactly, it's a low flow state. It's not a hypotensive state.
I agree. Unfortunately, there are still a lot of teaching on the fact that if your patient is not hypotensive, they are not in tamponade, and usually they arrest before they become hypotensive. But
anyway, thank you so much for all of you. And on behalf of my co-chair, I thank you, madam. I thank you, gentlemen, for this wonderful presentation. And I address to you as well for all of being here. Thank you very much for all of you to being here. As well, enjoy the meeting and enjoy Kuwait City. Thank you very much, everybody.